Is it taking?
Maybe 20?
Okay, try again. Yeah.
Okay, so I already showed this slide, so you can see that hepatitis deaths are likely globally to be shooting up in relation to the other major infections. So, you've probably heard about the Global Fund for HIV, TB, and malaria. Well, I wish I was there when they were setting up that organization so they could make it Global Fund for HIV, TB, malaria, and hepatitis. But unfortunately, if we don't do anything, we're going to see increasing problems due to hepatitis. And hepatitis, like many of these infectious diseases, disproportionately affects us in low and middle income countries. So now you might be wondering, I know I already mentioned this, why do we focus so much on hepatitis B? Why is it B? Because there's A, B, C, D, E viruses. Well, this is why. It's really due to the number of deaths. So globally, you can see that out of more than, I think, about 1.3 million deaths per year, 900,000 of them are from hepatitis B. And some of them, you can see in the black and the dark blue, are from acute hepatitis. That's the initial phase. Some of them are from cirrhosis and liver failure. And some of them are from liver cancer, which is called hepatocellular carcinoma. So this stacks up to more than 900,000 deaths a year from hepatitis B. But if I were to make this I can't make this for Zambia. I wish I could. I can't reproduce this just for Zambia because our vital statistics are not strong enough. And we don't have a way to track deaths from hepatitis in Zambia right now. It's something we'd like to do in the future. But if we were, I can already know what would be likely because we don't have much hepatitis C. So this would be very low. E would probably be a little higher, and A would be a little higher. But essentially, it would be even more skewed to hepatitis B. So that's why in Zambia, when we talk about elimination of hepatitis, how are we going to control hepatitis? Most of our effort is on hepatitis B. So I wanted to take you through the timeline because many people, when I start lecturing, they start thinking this is a new disease. Oh, hepatitis B must be a new thing. It's like, we had Zika virus, now we have COVID-19. There's always something new in infectious disease, but this is an old infection. And Ministry of Health has actually been involved in this for many, many years. It's just that, it hasn't reached population awareness, but the ministries have taken many measures already to address hepatitis. So it all started probably in the early 2000s when the blood bank was the first one to start doing widespread testing. So since the early 2000s, everyone coming to donate blood gets a hepatitis. It gets an HIV test, syphilis, Hep B, and Hep C, okay? So right there, the blood bank cut down transmission through blood donors. And by the way, 5% of blood donors are positive. So you can imagine how many people were getting exposed to the virus before this time. Then in 2005, 2006, the EPI program brought hepatitis into the vaccine package. And so all babies born after this time would have gotten vaccine when they were just 6 weeks and over. So this cut down the rate of hepatitis transmission again. Then in 2007, this is when the ART program brought in tenofovir as a first-line preferred drug. And so from that time onward, a lot of people with hepatitis were benefited, even though maybe we didn't know they had hepatitis. So bringing this drug in has really made a difference. And I know that government and PEPFAR and other donors, they don't recognize, there are these spillover effects. So of course they're focusing on controlling the HIV epidemic. There have been so many other side benefits. One side benefit is I'm very sure that this has benefited a lot of people with hepatitis B. Another big action here was Zamfia. So I'm sure many of you know Zamfia. It was a huge community survey, and they're repeating it just now, or maybe they've completed. So in Zamfia 2006, we put a hepatitis B test into the survey. And for the first time, we were able to assess hepatitis B at the population level in adults and children. So that's where, for the first time, we had high quality data. How can you operate in a in a program if we don't have data. So before this time, we didn't actually know what was going on in hepatitis. We didn't have like very good data. Suddenly we did. So we found that 5.6% of adults and 7.1% of adults with HIV, 1.3% of children, 5.9% of children with HIV had hepatitis B, meaning surface antigen positive. So for the first time, we kind of knew how many cases we had in the country. And then finally, starting in 2019, we developed the first hepatitis policy. So this just tells you, it's been a very slow process, but things have been happening. So these are the major historical things you should be aware of. So after Zamfia came out, there was a call to develop a task force. And so Dr. Sankal and I and many other local experts from different fields came together in 2018, 2019, and we looked at the guidelines from other countries, from the World Health Organization, and we looked at our local data, and our research data, and the Zamfia, and we put together our first guidelines, which were launched by Dr. Malama in 2019 at an event in 2019. So, what is hepatitis elimination? So hepatitis elimination is a global strategy that is being spearheaded by the World Health Organization. And the goal is by 2030, so that's about 9 years from now, we would like to cut the new infections and deaths from hepatitis. So we'd like to cut new infections by 90%, and we want to cut deaths by 65%. That's the ultimate goal of elimination. And so here we are in Zambia. Please ignore this column here. 2020 is not very relevant anymore. But these are some targets. So for example, third dose HPV vaccine. This means how many children received all 3 doses of the recommended vaccine. The target is 90% by 2030, and we are reaching about 84% or more according to the EPI program. So that means that 84% of the moms and babies, they go for all of their jabs when they're babies, okay? We know some of them drop out before the 3rd one. So all we need to do is just strengthen the EPI program slightly and we can reach our target of 90%. Now, birth dose vaccine, I'm gonna talk more about this in a second. Birth dose vaccine, we should also be giving it 90% of babies, but we're not giving it at all. So we haven't started. Now, blood donors being screened, we're already meeting the target of 100%. Chronic HPV diagnosed. So how many people in the population are diagnosed with HPV? We think it's less than 5%. So we're hoping to reach 90%. And so we have a long way to go on that indicator. For Hep C, we have no data. And then for treatment coverage, the target is that 80% of people who need treatment are on it. And we're starting off at 29%. Why are we at 29%? Well, the 29% reflects what's happening in the HIV program, what you guys are doing. So you guys, even without knowing a patient's status, you're actually treating a lot of hepatitis B in your facility. So probably we estimated using Zamfia data, that if you try to figure out how many people with hepatitis need treatment, the eligible ones, about 29% of the eligible ones are already getting it through the HIV program. Okay, so again, here's an example where you guys are focused on HIV prevention and treatment. You don't even realize you're also helping us treat hepatitis, and you should be applauded for doing that. You've already brought us from 0 to 29%. And then the next one is HPV incidence, so new cases of HPV. We focus on under 5s. And according to Zamfia, under 5s have a 0.7% prevalence. So this amounts to, I think, about 5,000 children every year being born with hepatitis. And we want to cut that down to 0.1%, just to hundreds of kids. We want to cut it from thousands to hundreds. And then finally, incident new cases of Hep C, we have no data, so we're really not sure where we are. So now let me talk about the different elimination indicators. So let's talk about the birth dose vaccine. So maybe you've heard of this before. So basically, one of the strategies to cut down transmission to small children from 0.7% to 0.1%, where we want to get to, is we need new interventions. We need a way to cut that down. Because what we're doing, we have our EPI program, it's working pretty well. It's reduced it down to 0.7%, which is great, but we need something more. And so the birth dose is basically the concept of giving the baby an extra dose of hepatitis B vaccine right at birth, even before they go home from labor and delivery. And what that vaccine has inside of it is it has the hepatitis B surface antigen protein, and it has an adjuvant to stimulate the immune system. And this helps the baby to fight off the infection if it's been exposed to it. The nice thing is it's very cheap. The vaccine, if it's bought in bulk, can be as low as 1 to 5 kwacha per dose if the government were to invest. And there's also a potential donor because Gavi, the Vaccine Alliance, which is already supporting other vaccines in Zambia, has said that although the vaccine is too cheap for them to buy it, they'll help Zambia and other lower middle income countries with the resources necessary to scale it up from implementation side. Because obviously there's more than just buying the vaccine, there are so many other costs. So the goodness is that we hope that this can be something feasible to use in Zambia in the near future. And unfortunately, I think one example of COVID is sidetracking other agendas, because if it wasn't for COVID, I think even by now we would have really gotten into the planning for this. Okay, so let's talk about a different indicator. So how about raising awareness of status? So this Venn diagram, in orange, this is Hep B monoinfection. Sorry, this is hepatitis B. This is HIV. So first thing to remind you is, from Zamfia, we learned that HIV is more common than HBV, okay? So you can see Zamfia, they found in Zamfia about 980,000 people with HIV, 460,000 with HBV only, and then there was the co-infected. So the co-infected is about 70,000 people, okay? So this is kind of, so you see the overlap. So I'll never tell you that HBV is more important than HIV. HIV is still more important, okay? So, but hepatitis B is there as well. So now out of the HBV mono-infected, about 450,000 people are probably unaware of their status. They're living with the virus, they don't know about it. They might be sick, they might not be sick, most are probably feeling fine. And out of them, we did a community survey in Lusaka province, in urban and rural areas, and we did tested about 5,000 people. And then from those, we tried to find out how many need treatment. And so using that data, we think about out of the 400,000, 120,000 need treatment. So you can see the pool of people we need to put onto tenofovir, to TIA, is not that high, right? So right now within, I don't know, can someone tell me, raise their hand and tell me how many people are on ARVs in Zambia? How many, and just throw out an amount, how many? Joshua. Okay, 1 million plus. So 1 million plus are on ARVs in our facilities. So if we can amplify, if we can be managed to absorb another 120,000, then we can treat all of the people who need treatment for hepatitis B. I'm not saying today, I'm saying by 2030. So that's a very realistic target, right? Because our facilities have so much capacity now that could, in the next 10 years, could they go up to putting another 100,000 onto the same drugs? I believe they probably could. But at present, we don't know about very many people who are on treatment from HBV monoinfection. Like the clients we have with us today from the clinic, you met them, you talked to them, many of them take treatment, but we only have about 100 people at ETH taking treatment right now for hepatitis B monoinfection. And then if you talk to other facilities, there are very few. Each facility has 5. So there might be as few as maybe 200 or 500 people in the country who are being chronically treated for hepatitis B monoinfection, okay? So we have a long way to go on treatment coverage. But for co-infection, this is what it looks like. So the co-infection are the group in the overlap here. So for co-infection, we don't know how many know that they're co-infected. That's one interesting element. So if you're co-infected, you're taking TLD, you're taking Tafid, you're getting your hepatitis treated, whether or not you know you have hepatitis, okay? So we don't really know how many of those are actually diagnosed, but we know that I think in the HIV programs, they're reaching, you guys have hit 90-90, right? 90-90. So that means if you take 90 times 90, you get 81%. So there must be more than 81% that are on treatment. So 81% of these patients are on treatments, and nearly all of them are on tenofovir because I think second line is like 5%. Can anyone tell me how many out of the 1 million, is it 5% on second line or 10%? What is it? Anyone guess? Does anyone know? How many are on first line versus second line out of the 1 million that Joshua mentions? Okay, well, it's a very low number, okay? It should be less than 10%. So almost all of these people with co-infection are on tenofovir, which is good, okay? So the coverage is very high when you think about co-infection, but the coverage is very low when you think about mono-infection. So these are the focus areas for Zambia. And after this, we're going to break you into small groups. I was told that you have 4 small groups already established from the other days. Do you guys remember which group you're in? Okay, so you're going to go back to that same group. And we're going to give you a topic to discuss amongst yourself related to elimination. Just a brainstorm, okay? Because although we're here to train you, we also want to stimulate and gather up your own ideas as to how we can achieve these targets in the next 10 years. So what we're thinking of overall is that we want to focus on the birth dose vaccine because we can cut the new cases down to the target. We want to focus on hepatitis B testing and linkage to care. We want to focus on treatment, optimizing the treatment for co-infection, and then start treating those with mono-infection who are eligible. And then as a hepatitis task force, we also want to close certain data gaps. We don't know enough about mother-to-child transmission. We know from Zamfia that there was 0.7% of under 5, but we don't know exactly which moms are transmitting, and those kind of questions still need to be answered. Hep C, we don't have much data. We only have data on Hep C from the blood bank, and there were several studies from a few HIV clinics. For co-infection, I would love to know what percentage of our co-infected are on tenofovir. Maybe we should be doing more testing in the ART department so that for anyone not on tenofovir, it should be required to get a hepatitis test. Maybe that's the approach. For mono-infection, we need to do to understand who's actually on treatment. Our M&E officer under the program for hepatitis, we went around to facilities, and it was very hard for the facility to keep track of how many people they've diagnosed, how many they've treated. And then finally, we need some data on mortality. Because if we want to show a benefit in terms of mortality, we need to be able to measure mortality. And so that's the end of my lecture on elimination. And so you're going to go back into your small groups for the next 15 to 20 minutes. And Dr. Mildred is going to give each group a topic, and then you read the sheet, you brainstorm on that topic, and come up with at least, you can put it into one PowerPoint slide, or maybe just come up with a very small presentation of 2 to 3 minutes, and then we'll reconvene and we'll ask each group to come back with what they talked about and what their ideas are for elimination of that one specific target. Back to you, Mildred. Just tell us about the fact of your elimination target and your assignment, and then this is what you came up with. We'll give you about 5 minutes, and then we'll have a little Q&A for us. Thank you, Dr. Allen.
Okay. Good afternoon, everyone. As I've been introduced, my name is Dr. Ronald Simsofe. I'm representing Group 2, and for us, the discussion or the indicator was on, apologies, we couldn't put it on the slide, but the discussion was on hepatitis B treatment, and the fact or the discussion is that by 2030, the global target is that 80% of people with hepatitis B and who are eligible should be on antiviral treatment. And the assignment was to brainstorm on ways we could understand how many people with hepatitis B are on therapy at our facility and how we can measure this indicator. So the first thing we thought of was to find ways. Okay, thank you. So the first thing we looked at was, I think as it has been highlighted from the discussion so far, we have clients who are on treatment, but the issue is to know how and where they are on treatment. So the first thing we looked at was understanding how or understanding the number of people who are on therapy. And in this case, we needed to find data sources which we can use to identify those clients. And of note, we looked at one, we need the hepatitis B screening tool. Okay, we need an hepatitis B screening tool in both ART and the general population. ART, we need to know, I think from the presentation it was highlighted that people are on treatment, but we don't know how many. So that will help us to capture that data. Then secondly, we need the testing register. This will just be for hepatitis B, such that when we know that the way we do for HIV, I think it helps us to identify who was tested and the result. Then those who test positive, they will need to be screened according to the criteria that has been provided, such that if they are eligible using that criteria, they will be put in the treatment register. And we find that we'll be able to capture the information from the treatment register of what we are looking for. Then the other part is the contact tracing register. Considering the fact that this is mostly familial and all, there is need to contact trace all the index from the person who was tested positive. So that's for just the general population. Then specifically for pregnant and breastfeeding monitoring, we need to have also a mother baby pair register so that we can do cohort monitoring for those babies that are born from hepatitis B positive mothers. And then there's also need to include hepatitis B in the health management information systems, so that even that data is kept and it can be generated so that we have a wide picture, which can also include mortality and morbidity from hepatitis B. Then in terms of process indicators, what we came up as a team is we need to determine the positivity rate. So from these registers, if you look at the testing register, it can give us, when you look at the total number of people who are positive, and versus the total tested times 100, it will give us that positivity register. Then on treatment register, we need to look at the total number of people on treatment, and this is with the eligibility criteria in mind. And then we'll compare that to the total number of positives which we have at facility level times 100, and that will help us to identify the treatment rate. That's the end. Thank you so much.
Thank you very much, Group 2. We have time for just one or two questions or clarifications from the audience. That's fine. So we actually had a small communication breakdown, and so we're going to break for lunch earlier than expected, and then we'll come back half an hour earlier because of the way they're doing lunch here. So I think we're going to break for lunch now for the next hour, and before we go, make sure every group is given their presentation to chat. Come back, we will start with the rest of the group presentations. Thank you all for your attendance and your alertness this morning. Don't read too much SEMA, okay? I don't want anyone going after minute. Of course, it's hepatitis, so no alcohol, please.
Yes.
Okay, so good afternoon. Lukongali Ken, being commenter from Western Province. So we'll give a presentation for group 4. So our scenario was on hepatitis B index testing. So in Zambia, household and sexual contacts, as well as the first degree relatives of people living with HIV, are 2 to 3 times more likely to be hepatitis B positive compared to the general population. So our assignment was mainly to brainstorm some strategies we can use to do HPV index testing. And for each strategy, we're made to discuss whether it's more or less time intensive or more or less resource intensive. So some of the strategies that the group came with, mainly with index testing, you have to ascertain and obtain consent from the index patients, of which you don't have to just go ahead and do index testing without obtaining consent from the index case. So you also need to counsel the clients on a possible referral system. So we are borrowing this from the HIV program, of where we have different referral systems that we offer during index testing. So one of it that HPV can also use is client referral, of which we offer the client to bring their contacts so that we can test them. So this one said that it's cost effective, but it's time consuming because it depends with the clients. Maybe they can take time for them to convince their contacts to come for the testing. Then there's also dual referral. So for dual referral, this is where the healthcare worker and the index, they notify the contacts and offer the testing. So this one maybe, as a team, we said it's cost effective and time effective. So for us, we think it's time effective because the provider is involved. So they'll easily do the contact on time. So there's also provider referral, where we decide that the provider goes and offers index testing themselves without the client being there. And there's also contract referral. So for contract referral, it's where you give time to the client, maybe 2 weeks for them to notify. Then if they fail, then you have to engage them back. So for this one, it's time, it's not time effective because it has to be for a period of time. Maybe you make a contract for 2 weeks. So it will be maybe beyond your time. So they also discussed that we can have a targeted text messages. So this one, there was an example of, we can say like a version when you're doing retention. So they normally send messages to all those that have missed appointments, but for this strategy, for HP index testing, you send it to the contacts. So the message really don't say, oh, you've been mentioned, there's someone who has who has hepatitis, but they'll just send a message to attract you for something that will make you come to ask and find out. So this one mainly it's time effective because the message you just go there and then, and not really cost effective. So the other thing that we discussed was in the HIV program, we have know your child status of where you're using the mother who is HIV positive to reach out to the children. So for hepatitis, maybe we can use it in the way of know your family status, of which if the index is your index, you try and reach out to the household, the entire household, instead of just the children in the approach of when it comes to the HIV program. So here you can also use the PNS, of which in HIV program, partner notification. So if in hepatitis, the partner, they notify their other partners because you might not find the partners in the household, but you can reach out through using the index to reach out to the partners. Then also the group said we can still enhance sensitization programs even to catch more cases for hepatitis. Thank you.
Can I ask a question? We said that could you go back to talk more about tool testing, tool referral?
Yes, on the dual referral, it's where you're using the clients themselves and the provider, so you're doing it together. Maybe the index is not comfortable opening up to the contact, so they need your help and they really want to be there. So you do it, the two of you.
Do you envision that would happen at home or in the facility?
So that one, it depends with the index case. If they allow us to do it in the facility, if they're okay with it, it can happen at facility. If they're okay at home, it can also happen at home.
So, I mean, in that scenario, the index would tell their family member, I need to bring you to the facility, but I can't tell you why. And then I'll tell you when we get there. Is that what you were talking about? Something like that?
Exactly. So it can be that they are not okay opening up the real issue, but they can make the contact come to the hospital. They can find other reasons to make them reach the hospital, but not telling them the whole truth.
Do we have any successful incentive kind of programs or something to bring contacts? I remember so many years ago with PMTCT, we used to give those referral cards to the man, and the mom would go after antenatal. She would go home and she would give the card to the man and say, like, bring this in, fast tracked for knowing your status. Do we still do anything like that? Are there any systems where like our index might bring something home to say, this is like a voucher, you bring it to the facility, will be attended to?
Not really. I don't know, maybe from the team.
My name is Tasha. I think under co-op, we don't have such a program where we don't need to come and then we give them something next week for them to do that. Yes, as well as some of the partners that we're working with at some point that we do that. And And those partners have still spoke to such things. So for us who are here, if we don't give such incentives to the clients.
The incentive was that if a woman comes to antenatal with her partner, then she's prioritized, right? So could something like that be considered in other departments like this? So if you bring a relative with you, you'll be prioritized or something. Okay, nodding your head, yes. I saw a question or comment in the back. Anything back there?
Yes, actually, I wanted to say that if someone comes with a partner, we could be the first priority. We see them and they go back home to attend to other duties. Thank you.
I love that because it could also be a way to convince the partner. Because if you tell your partner that I'm going for a review, and if you come with me, you'll allow me to fast track. Then it's like, oh, okay. I know I'm helping you if I go. The other question I had for follow-up is about SMS. So how successful are these SMS? I did a small tracing program once, and very few people responded to the SMS that we sent them for patients who are lost to follow. So I'm just wondering, does anyone have any positive experiences where they say, hey, this is really powerful? Oh.
So for SMSs, I would give an experience from Senanga district. I think we had more issues with retention, but when the partner came in, that's subvention, and what they just do is SMSs, they don't call. So despite clients not giving feedback to say, I'll come, when you compare the people they've enrolled in the retention program, you find that their retention always is about 95%, and mostly some quarters it's even 100%, which shows that actually patients acknowledge the messages.
Yeah, maybe just add to that. From the same district as our Vinikoor as well. The partner does provide an incentive. If you keep the line open and you keep the appointment, you receive some talk time. Yes, so I think that does help. Then before enrollment, you talk to the client if they are willing to be contacted in such a manner. Because some of them will share efforts and they wouldn't want such information to be seen by everyone. So they have to consent and then the whole process starts.
Thank you, Group 4. Thank you very much for my round of applause. Group 1. Do we have a representative of Group 1? Group 1 focused on that 90% of people with HPV know their status, and their challenge was to brainstorm a ways to understand testing and measurements in their facility. Looks like they came up with trainings on HPV testing for the staff, so in-service trainings. Number 2 have HPV testing SOPs. So I assume there'll be HIV testing SOPs, so those could be 1 to 5. Make sure that HBsAg reagents are available. Number 3, number 4 is to create targeted groups. So for example, one group that could be targeted for testing would be ART clients who are not on staff availability. As an example, I could think of other groups that would be targeted would be anyone with a raised ALT in the laboratory. Or partners, We just talked about ex-clients. OPD, HPV symptomatic clients was also mentioned. I think that's more or less like PITC. So when the doctor would refer people with any, signs of a liver problem for testing. And any client with a family history would be referred as well. Any other slides? All right, group one, no one is with us? Okay, let's move on to group two. Anyone from group two would like to speak? Oh, sorry, group three. Thank you.
Okay. Good afternoon. I'm Lauka, representing Group 3 members. And for our question, we're looking at persons living with chronic hepatitis B monoinfection. The need for a chronic care model, a model that would be able to, take care of the various aspects of the continuum of care for people with hepatitis B monoinfection, with regards to repeated lab tests, clinical reviews, as well as pharmacy pickups, and where this model can be implemented, and what are the major barriers to implementing such a model. So where can this model be implemented? The answers that came through ART clinic, as well as medical clinic. Now, when we talk about the medical clinic, when we talk about higher facilities, we're talking about a specialist medical clinic. And in the district hospitals, could be OPD, they usually also get to have medical clinics for chronic conditions like hypertension, diabetes. So our method, we didn't really recommend a specific one. We just decided to highlight the pros and cons for each of the models. And based on each area, probably those cons can be able to be tackled depending on the circumstances. So under the ART model, we could just say there's access to medication. The medication that we use for hepatitis B clients are already available in ART. And there's already an existing lab follow-up system for the biochemistries, which is like the ART. Those are part of the care cascade for ART clients. So taking advantage of that. Then tracking retention system. So these are clients that might need to be tracked in case they fall off from care. And riding on the retention system that is in ART systems, this can be able to help. Then clinicians conversant with drug use. So the drugs that we use for treating clients with ART, also the same ones for treating hepatitis B clients. So we already know that there's issues of adverse effects and the like. So riding on their knowledge of these ones, they can easily be able to deal with them. Indexing components using ART model. So in case of new case finding, that can be utilized under ART model. Then smart care optimized in ART. So as a way of tracking the system of recording these clients, in our various provinces, facilities, it's on ART where smart care is optimized. OPD could be using it, but not in an optimized manner. So riding on this, it can actually really help out in the rollout of the hepatitis B care cascade. Then the cons, stigma. So under stigma, not to say when someone has come for collecting their medication, they are associated with HIV, or people might think that they also have HIV. And this was actually picked up from one of the patients that was seeing, because they were thinking that she's also an HIV patient. Then the long queues, remembering to say there's also ART clients being seen who are a lot. So there is an aspect of long queues. So remedies to tackle some of these cons in the ART, introducing a fast track model. This was to tackle the second con where we're dealing with the long queues. And then IEC as a way of tackling the stigma aspect. You know, the more you teach patients, the more they start learning about the condition and the more they start understanding. Counseling as well can also help to tackle the stigma aspect. And the medical clinic model, the pros include specialized care. When you talk about higher facilities, these specialist clinics are being handled by specialists. So you are affording the patient an opportunity to be seen by a specialist, and thus the quality of care is also optimized. Then there's also reduced stigma because they'll just be part of the pool of the patients that will be seen in that clinic. Then specific days assigned to hepatitis B. These specialized clinics usually have specific days for each condition. For instance, they might have diabetes mellitus day or a day for hypertension, so they can as well assign a day specifically for hepatitis B as well. Under the cons, the likelihood to be mismanaged is there in that in the district hospitals, these clinics may be run by anyone, and any doctor, including those ones who may not be well abreast in terms of managing hepatitis B. So chances of mismanagement are there. May establish system for hepatitis B program care and treatment. So this looks at the logistical aspect, client follow-up, the registers and the like. So without these ones, that can pose a challenge for managing this program in this kind of a model. The lack of structured counseling services in OPD, unlike ART where there is a space specifically for counseling where you can be able to direct these clients, OPD may not have this. So for remedies, in case this model were to be utilized, it might require capacity building. Probably to add on to that, there could be a need for systems developing to allow OPD to be able to handle such kind of clients. This is it. Unless there are any questions and concerns.
Sure. Are there any lessons you all learned from setting up PrEP within the ART clinic that could be translated over to bringing Hep B into the ART clinic?
Okay, we will answer it from the experience at our facility. Initially when we started out for PrEP, we were not, including it in smart care or single off smart care. And we noticed that we were having lots of attrition of clients. Okay. Whether you look like you wanted to respond to that? Okay, go ahead.
Okay, so, yes, I think, well, I'll speak from what happened at the office. So, yes, we have a lot of DST models and we are seeing fewer patients per day, and we have integrated PrEP into ART. For us, what we had initially planned for certain populations within PrEP, we do have specific dates, but for key populations like MSN and that works very well for them. And so that's about the question. And I think when it comes to the hepatitis B program, yes, to that point, I think it would work quite well within ART as long as we have a specific DST for them as well. Yeah, thank you.
Similar to us, yeah, the DST models have really helped to, slash down the numbers, and now the introduction of the community posts, some more clients are being, channeled to there, so that further reduces the numbers. I think can allow for some space for a program like the hepatitis B program. And riding on the 6-7D DST model, I think it can really help. Yeah.
Thank you. And I also just want to say, I talked to one of your colleagues during lunch break about how smart care, bringing private smart care is also now a way for the program to pull out the PrEP clients when they're doing the reporting, so that they don't accidentally get counted as retention problems or something like that. Because of hepatitis, we have to be very careful not to disturb those indicators, because 60% or more won't be started on treatment. So we wouldn't want it to look like someone is enrolled and then they're not started, because that could make the HIV program look bad. So.
Oh yeah. So I guess it's something that I guess might have to be discussed with the M&D team. Yeah, we did notice for some clients where the PrEP clients were being counted under the TX and that would, to some extent, alter the other indicators. But the goodness is PrEP clients are, the number is smaller. And so even the effect on the overall indicators is not as much. So I guess talking with the M&D team, which is ever present, I guess something can be done so that the hepatitis B clients can be differentiated from the rest of the ART clients. Yeah.
Thank you. Was that the last one?
They was, but they don't here.
Oh, okay. Let's go on to the next section. Okay, so we're just calling this next 15-20-minute lecture HIV-HPV interactions. Next slide, please. Okay, so as I mentioned this morning, ART, first-line ART, which is comprised of TAFID or TLD, excellent treatment for those patients with HIV-HPV co-infection. So I just want you guys to remember that for some of you who've been doing this for a long time, this was one of the very central reasons why we wanted tenofovir in Zambia as our first line, and why we're one of the first ones to adopt TAF as well, because the high-level policymakers are aware of hepatitis B and it's common as a HIV co-infection. And so that was a deliberate decision, and that's why the tenofovir has really been a blockbuster drug in this part of the world where you have both infections commonly happening.
But just remember that we're doing it blindly. So for the most part, we're not testing patients who live with HIV for their hepatitis B. And it's in the guidelines. So if you read the Ministry of Health guidelines, even going way back, it always said one of the baseline tests you should do for anyone who's just diagnosed with HIV is check HBV. But we're not really doing it. And I'm not necessarily that concerned because we already have treatments. So the benefits of testing are not immediately important at that point. However, it would really help with index testing and there would be other reasons to do it. But for the own person's health, it's not going to have an immediate benefit. So just to keep that in mind. Next, I wanted to talk about treatment as prevention. Okay, so just as we talk about U equals U, right? HIV treatment is HIV prevention. It's also HBV prevention, okay? So your clients in ART who have HIV, they're HBV negative, when you put them onto TLD or TAFID, you're like putting them on hepatitis prep. You can think about it like that, okay? You're giving them other benefits that we can't even discuss with the clients because they won't understand since they don't know hepatitis. But you should just remember, you're also giving them prep against hepatitis B. And given that we know there are 500,000 people in Zambia with hepatitis B, they're likely to get exposed. Just going around the community, doing their, they have interactions with people, and so hepatitis B is around. And so just keep in mind, that's another benefit of TLD and TAFID is that it's hepatitis B prep. And so actually we're following a group of about 350 people in Kanyama, and they all were HBsAg negative, and we followed them for about 4 years. And we kept checking Hep B every year during the follow-up, and we didn't see any that came through with hepatitis B. So now, of course, we don't know exactly what behaviors they were doing, who they were sleeping with, or what other opportunities they had to get hepatitis B. But in general, this gave us some information that these ARVs are really keeping people free of hepatitis B. So it's just another, as you guys think about your work, you're thinking about U equals U, but it's also prepping for hepatitis B. Now I'm going to flip it over and I'm going to talk about HBV treatment is HIV prevention, okay? So now we're almost thinking about PrEP here, right? So when you treat someone with PrEP, or when you treat someone with HBV, you're now preventing them from getting HIV, whether you intend to or not. And so Dr. Sinkala and I published this case series I wanted to go over with you guys because I think it's very interesting for clinicians and HIV people. So basically within our UTH cohort, we test everyone for HIV and they only enter into our cohort if they're HIV negative. So if they come in with co-infection, they usually go into AIDC, routine ART. But we're more focused on HBV mono-infection. And so during the early years of this program, we actually found that 5 of the people, after their 1 or 2 year follow-ups, they were now HIV positive. So these were people that were HIV negative, and after 1 year of follow-up, or 2 years of follow-up in one case, they became HIV positive. So I wanted to talk about this. So the first patient was a 28-year-old male. And you can see here, when he first enrolled, he was definitely immune active, right? So he had the high viral load, 23,000, and he had the high ALT, 79, okay? But what happened was I forget what happened. He had a work thing, he had to travel for work. So by the time we got his results and we called him to come back to start treatment, he was busy. And so it took him maybe 6 or more months before he came back. He finally came back to Sister Annie and we started him on treatment. We discussed it with him and we said, you need treatment, here's treatment. And then when we were following up at the 1 year follow-up visit, his HIV was reactive. And by chance, we had a stored sample from the baseline. And so we went back and tested it from when he first started treatment, and it was also reactive. So basically, between the time we first enrolled him and that 6 months or so later when we called him to start treatment, he must have seroconverted. So now, on the basis of this case, we now recommend that on the day when you're going to start treatment for someone with Hep B, you should re-know their status. We know in the PrEP clinic, you do HIV testing after 3 months, isn't it, right? It's even every 3 months. So for our clients, even though we may not know them to be high risk for HIV, if they qualify for treatment, when they come back for treatment, before we start, we just double verify their HIV status. We have now some HIV testing kits, and we have Mika testing them so that we can just be sure that this doesn't happen. But the goodness here is that when we found his HIV, we did the viral load and it was undetectable. So even though he was only taking Truvada, his HIV was undetectable. So he hadn't gotten resistant, right? So that's good. So now let me talk about patients 2, 3, and 4. So these were 3 men, 30, 23, 38, and you can see the viral loads are so low, 53, 85, 200, compared to the first one, 23,000. And look at the ALT, 33, 26. So these patients were inactive. So based upon our assessment, they were inactive, so we never gave them treatment. We just followed them up. And sure enough, after a year or maybe 2 years, they turned positive for HIV. So again, these cases were hard to stomach because had we started them universally on treatments, maybe we would have prevented them from getting HIV. We just don't know. But we were following our guidelines in Zambia, and they weren't qualified for treatment. So there you go. And this is the last case. So this was a patient, he had been on treatment for several years, like 4 years, I think. And when he first started treatment, look at this. His viral load when he first started treatment was 170 million, very high viral load. And his ALT was 110. So he was definitely immune active as well. So he's in that immune active category. And when he came in for one of his yearly reviews, his HIV was positive. So now we were really scratching our head because I told you treatment is prevention. So we're saying to ourselves, if he's taking his treatment, how can he get HIV? Well, it turned out we called him for we got a sample on him, and it turned out that his viral load for HPV was quite high. So when we looked back at his pharmacy records, there were gaps. So probably this gentleman was not adherent to treatment. So when he got exposed to HIV, he wasn't on it. It was like a PrEP failure, if you will, right? The client wasn't actually taking their PrEP. And this was an extra tragic case in a way because when we saw the high HIV viral load, we actually sent it for resistance testing because we're so interested in this case. And he did come back as having resistance. So he was actually had to go on to second line ART right away. So he couldn't be on tenofovir, it's the standard treatment. Actually, this was before dolutegravir was even there. This was like 3 years ago. But so essentially, this patient taught us that adherence is very important in our patients, and repeat HIV testing is important. And obviously, it just reinforces that PrEP only works when you take it. And you guys would already know that. Yeah, so I'll talk a little bit more about PrEP. So many of you have been now building up a lot of experience with this. And I would expect that if, according to the guidelines, people going on PrEP should be tested for hepatitis B. I don't know, a show of hands, how many of your facilities are doing that? Are they actually doing that in the real world? I'm just curious. Raise your hand if your facility is doing Hep B testing on your PrEP patients. Okay, we've got 1, 2, anyone else? Okay, that's interesting. Because basically, probably according to the epidemiology, about 5% of those people would be positive. And so in a way, you're giving them early, you might be giving them early hepatitis B treatment, which is not necessarily a bad thing. But the guidelines say that if there is a patient with Hep B who needs to go on PrEP, when you are done with PrEP, maybe they've now changed their behavior. If it's a sex worker, maybe the sex worker is no longer a sex worker, and they come to you saying, "I'd like to stop this PrEP." At that time, you're supposed to reassess their HBV and determine if they should remain on treatment for their hepatitis. But I am not aware of how this is actually happening in the real world. We need to think about some kind of guidance for facilities on this, especially as they do more hepatitis testing. The reason for that is there's theoretically a high-risk situation here, because some of the people with hepatitis B have cirrhosis, which means their liver is scarred. And so those patients, if they stop their PrEP suddenly, they could have a life-threatening flare-up of their hepatitis. So I've never heard of any case of that, but there is this risk because I know from what I know about PrEP is that some of the clients are very difficult to work with, and they go on PrEP, and then after a month or after 6 months, they drop and they disappear. So continuation of PrEP is, I think, one of your main challenges. And so if patients discontinue their PrEP, and they happen to be one of these Hep B clients, they could get very sick in theory. And so, I don't know when we'll get to it, but at some point we're going to have to think about developing some, and maybe this will come with when we bring hepatitis integration. We'll think about how to manage these patients. Now, I guess one question for you all is, do you ever discontinue PrEP, or is it the patient who discontinues? Can you raise your hand if you as a clinician have discontinued PrEP on someone? Has anyone here decided to stop PrEP? Okay, it's not yet a problem. Okay. Yeah, I think it probably is, that we've only been doing PrEP for a few years now, and so the people who go on PrEP now really, really need it. So we probably don't discontinue because we know they need it. But one way to think about this is if your client goes on PrEP and they have HPV, then you might be able to just convince them to stay on it for life, because you could tell them, listen, this is killing two birds with one stone. You're treating your HPV and you're getting prevention. So there might be a way to motivate them to stay and continue PrEP, because you can tell them that it's not just HIV prevention, it's also treating your hepatitis B. So again, I wanted to bring that up so you guys are aware. This is one programmatic interaction that's happening. And then I think on testing, it's pretty straightforward that integrated testing should be very easy to do, because HIV testing, is with an oral swab or a finger prick. You get the results back in minutes, up to 15 minutes. With HIV testing, you require a confirmatory positive. With HBS testing, there are several different rapid tests. And similarly, finger prick is available. There's no self-test, oral self-test for hepatitis. The results are available in 15 minutes. And with hepatitis B, we don't require confirmation. So if the test is positive, we take it as positive and we can move on to the treatment program. So we don't need to reconfirm. Okay, here's another area where HIV and HBV intersect in Zambia, which is PEP, post-exposure prophylaxis. And I realize there are different times when we do PEP. For example, maybe after gender-based violence, but I wanted to talk about healthcare workers and PEP. And so essentially, a healthcare worker is exposed to a contaminated needle or equipment at the facility, and they now have come to your clinic and they open up a PEP file. So as part of that, you're going to do an HIV test, but also they should be tested for hepatitis B. And actually, we had a number of referrals to our program from health workers who were diagnosed with hepatitis B because of finding their status because of a PEP or exposure. And if the person is HBsAg negative, so if they're negative, on top of just giving them ARVs, we would suggest give them a dose of vaccine. That might help to reduce the risk of hepatitis B as well. And then for hepatitis B, the window period is shorter than HIV. So in HIV, we talk about maybe a 3-month window period when you can seroconvert. But in hepatitis B, it's 1 month until the surface antigen becomes positive. So at the end of a month of post-exposure prophylaxis, you can recheck the HBV and know that they didn't get infected. And then, of course, your PEP usually contains tenofovir. So again, you're giving post-exposure for hepatitis B as well. So hopefully by now you're getting a sense of all the ways that Hep B and HIV go together. And then I also want to put in a plug for the Option B Plus program. So we've actually really cut down the Hep B transmission in these moms with HIV. So, in general, as I was saying to one group here that it's very paradoxical, but if someone with hepatitis B also has HIV, there are so many services we can provide to them. But if they have HBV and they don't have HIV, then things get more complicated in the real world because the services are not geared towards those patients. So I would imagine that there are more transmission from mother to baby in the HIV negative moms than in the HIV positive moms, if we were to measure that. And then the last thing I just want to talk about, I think it came out a little bit on the patient presentations this morning, was what I call stigma by association, or it could be called transferred stigma. So as we all know, community awareness of HBV is low, and therefore most people who have HBV are assumed to have had unsafe sex or take drugs. Because if you do a Google search on hepatitis, a lot of people come out concluding that it's more of a disease of key populations like drug users. But it's really not true. And I opened your eyes to the fact that most people with hepatitis B in Zambia were infected at birth or in their early childhood years. It has nothing to do with any behaviors they did later in life. And so therefore, when we put these people on ARVs, i.e. tenofovir and lamivudine or tenofovir and tracidovir, it's very hard for them to bring that ARV bottle home to their family and put it in their bedroom. Even more than, they hide their medication, just like the ones with HIV, because they're afraid of stigma. And also some have even experienced stigma as well. And so, we did some qualitative study a long time ago, and I think there were even some marital, issues that came out, some fighting when people found out they were taking ARVs. I mean, imagine if you were, just tonight, you had an ARV bottle in your room, and then you said, oh yeah, that's not what you think it is. I have this condition called hepatitis. It's not HIV, it's called hepatitis, but it's the same medication. Who's gonna believe you, So this brings in a lot of challenges, and we encourage all of our clients to bring their spouses and people from the family so that they can get education at our facility. But it's an important issue, and really we need to work further this issue. Okay, thank you very much. And so now we're going to have a session on data, M&E, I believe. Is Bob Chirwa here? Is he talking?
From our clients, is that most of the investigations were done through blood. From my experience, from the hospital that I'm working, and notification from the other centers, so I think from the other ladies, I'm sure the cancer I have come across with has not been notified. So I feel like it is a bit biased, considering the source of the data.
Thank you, that's great, that's a great point, yeah. We do have data gaps. So the blood bank is the main center of hepatitis B testing in Zambia. I don't know the numbers, but they may be testing more than 100,000 or 200,000 people every year for hepatitis B. And so since 5% are positive, that means that they must be finding 10, 20,000 cases every year at the blood bank. And I'm not well versed in how they link that to care or how they report out that data. But certainly blood donors are a selected population. They're very young, very healthy, but as you say, blood donor data is not, can't paint a picture of the whole Zambia. But essentially we know that transmission is more early childhood and vertical just based on epidemiology from the region. We don't necessarily have those studies in Zambia, but there were several small studies in Zambia from the 1980s that showed that babies right at birth, the prevalence was maybe 1%, and then by 1 year, 2%, and then by 2 years, 5%. So they showed that there were actually new cases occurring in children. And so that, and that's basically a consensus in this part of the world that it's vertical and early childhood. Now, as far as sexual transmission, because some of you may be wondering, how many cases are there of sexual transmission? We don't really have data on that. Sister Annie and I receive a referral for acute hepatitis B every month, maybe 2 every month, 3 every month. And those always tend to be people in their 20s, maybe early 30s who are sexually active. But we don't really, we can never really know what the exposure is. So it is happening. I suspect there is sexual transmission, but I can't really be 100% sure how much is happening. But I also want to just reemphasize that if one of our clients comes with acute hepatitis after sexual exposure, remember they're adults. So 95% or 90% are going to clear it up. And so only 10% will be left with chronic infection. So most of the new chronic infections come from those young children.
Yes, I would like to be enlightened on the high viral load. How will you tell that this high viral load is caused by hepatitis B virus and is not HIV, especially that the hepatitis B is also in a chronic form?
Thanks. I mean, the technology that we use to measure hepatitis B viral load is the same. It's PCR. Now with COVID, everyone knows what PCR is, right? We now know PCR. What you do with PCR is you have a primer and you incubate the primer with the sample, and the primer is very specific to the virus. So it could be COVID, it could be HIV, it could be hepatitis B, hepatitis C, any virus, you have a primer. And then you put it in the machine and amplify to see if it's there. And so basically we have it's a different testing kit than hepatitis from HIV. So if we have a patient and we can test for HIV viral load, hepatitis B viral load, so they're basically different tests. Did I answer it? Did I eliminate you? Thanks. Please.
Thank you very much. So in line of the same viral load for hepatitis virus, I wanted to find out, is there anything like the way it is for HIV viral load in terms of transmission? If someone has got a high viral load, the chances of transmitting for HIV is high. And then I wanted to find out how it is for
yeah, people with high hepatitis B viral loads are also more likely to transmit.
Just a follow-up. Now, what about the transmission rates for breastfeeding mothers for hepatitis B? Is it still the same?
So hepatitis B does not transmit through breast milk. The only time it could possibly transmit is if there's bleeding of the breast. So if there's bleeding of the breast, just like HIV can increase the risk of transmission. But basically, hepatitis B transmits from mom to baby at birth, because the baby is exposed to mom's body fluids and blood. So that's like a big exposure. And so, yes, it's the same, exactly what you think. You're very right. The mom with a high viral load, when she gives birth, she's more likely to pass it on to her baby compared to the mom with a low viral load.
Thank you, Dr. Vinikoor, for the information. My question was with regards to the research that you did for the last patient, patient 5, who defaulted, was on second line. So without tenofovir being part of their ART regimen, how did they treat it and how can you treat a similar patient?
Annie, Sister Annie, you might remember that. So once we recognized he had HIV, we put him on to TLE at the time, right? TLE was our first line back then. But then when we got the drug resistance test back, and he was resistant to tenofovir, he had a 65R mutation, and he also had the N184 mutation from the pigment, and he also had some TAM mutations. So at that point, we knew we needed to put him on second line. So I think he went on to Aluvia plus probably AZT3TC. And then for his hepatitis, we still put him on tenofovir with lamivudine. So he ended up with a double dose of lamivudine. So he was on Aluvia plus AZT3TC plus tenofovir lamivudine. Tenofovir 3TC. That was his regimen. So he was on a lot of things. That was dolutegravir. Unfortunately, he ended up passing away, so he never got to benefit from DTG.
Thank you so much for this comment. I wanted to kind of mention the issue of community sensitization. So I wanted to find out what media is being used to engage the community. Because I think looking at it, we are at the gap in terms of knowledge in the community. And I think if we can increase the community sensitization to the level which are with HIV, even all these issues of stigma and discrimination, so what media is being used to bring sensitization? Thank you.
Yeah, I mean, we honestly don't have a big budget for that. We have a lot of speakers who can go on radio, TV, etc. But we a lot of times have to wait for opportunities that might come up when we're invited to come to a radio show. And so it hasn't been as widespread as we wanted. In fact, I would say that for now, we believe that resources should be more channeled to training and building awareness of healthcare workers. Because we've heard from some of our patients that even if they're diagnosed, if they go to their local facility, they don't feel the healthcare workers have the information that is needed to serve them. And so, our vision is really to get the ministry to include some resources for this around hepatitis going forward. And but really the priority would be healthcare worker training and giving you all and your colleagues that information. This is why we're also kind of working on Project ECHO and other educational platforms throughout the health system. So general population sensitization is really important. But for now, when we have resources, we're trying to channel them into health worker capacity building. Because we feel like if we give you guys the information, we'll be more able to spread it even better than me or Dr. Sikala or Dr. Monze or someone else going on radio. So that's what we're starting from right now. But if you feel otherwise, please let me know. Do you think we should put more into community and less into healthcare workers? What do you think?
I'm looking at the fact that the program is very selective. I think information is very good, very paramount. And then once they are able, they can now put develop.
Thank you so very much. One of the clients that we interviewed this morning, we stated that she had been a black donor from 2010 to 2015. So one thing that has surprised me that she was never informed at any time, even this video that she had hepatitis B, until the time of this diagnosis was made at the hospital. My question and concern is that we do have a delivery system where the client can conduct it upon the rights and the lab that the client will communicate with hepatitis B virus.
Yeah, thank you. That's a really good question. Yeah, my understanding of the blood bank is they collect the sample. I don't know, is anyone here donating? They want to talk about the procedure. My understanding is there's a questionnaire, and the questionnaire is supposed to screen out people who are very high risk for infections. So if you go through the questionnaire and you're very high risk, then they decline to take your blood. Most people, they go through the questionnaire, everything is okay. Then they collect your blood, and you go. And then later, they bring that blood to the laboratory, and they test it for those 4 things: syphilis, HIV, hepatitis B, hepatitis C. And then they get the results, and they're supposed to call you back to give you those results. But there must have been a breakdown in that process of giving the results. It is possible that she was infected with the virus later, between when she started and when she ended her transfusion, but I suspect that they probably just didn't communicate the positive result to her. Because in fact, even our own program, sometimes the blood bank will ask us to help them with referral, give us referrals or help us follow these up, follow up clients. So yeah, it is a problem. Thank you. In the back.
Thank you very much. Next one. Find out transmission. Because we see in HIV, we have the new code. And those clients that are interested as well, they are suppressed. They actually can live no life. They are married and don't have a family, without institution because of HIV. So I don't know that in the case of hepatitis B, in a situation like that, where the hepatitis B patient can reach a stage where she or he can live no life, even to having family.
Thank you. I've heard that several times today, and actually, in hepatitis B, we're in a better position than HIV because with HIV, there's no vaccine. With hepatitis B, there is, and so people they can get their partner tested. If the partner is negative for HPV, they can get vaccinated. Once the partner is vaccinated, there won't be any spread. If it's a woman who's positive, we have PMTCT for hepatitis B. We have different interventions available. And so, yes, we do counsel our patients in the same way that there are options available. It's not hopeless. They should go on with their lives. And we tell them that, you should treat this like high BP or diabetes. It's a chronic disease. There's so many of them. You should just realize that you have what you have it, and you'll have to go for reviews and you have to do certain behaviors. But if you do those, you'll live a normal, healthy life. That's what we tell our clients. There's no reason they can't meet family, work. Yeah, I think we're not as advanced on the messaging, but that's how we counsel our clients. Okay, quick one. All right, one last question.
Just in addition to what we there was one of the ladies, her baby had to be trying to stop breastfeeding at 8 months. Yeah, so I'm thinking the kind of vaccine is considering that those that are like getting those that stop only before 6 months. Yeah, so the baby vaccinated and the child virus down. I'm just wondering why so how come the breastfeeding?
Yeah, and Sister Anna. There's a question about one of our participants. She was told to stop breastfeeding at 8 months. I don't think that was from us. But do you remember about? Yeah, I mean, it wouldn't have come from one of us because that's not based on any evidence. So yeah, as you said, if a mom has HPV, we have interventions, including the birth dose vaccine, and then the baby will get vaccinated. So therefore, even if mom is breastfeeding and develops a breast infection, which can put her at risk of spreading, the baby would have been vaccinated by that stage. And the vaccines, if their baby completes the series of vaccines, it's like 99% effective. So it's a very good vaccine. So that's why I'm saying that compared to HIV, there's a lot of hope in hepatitis B because we have a vaccine, something that HIV doesn't have. And we're working on a cure too. Okay, so let me pass the microphone over to Bob for a presentation about M&E. Thank you.
Okay, good afternoon, everyone. My name is Bob Chira. I work for UTH under the HIV/AIDS program. In particular, we have a program called Accelerate, which is basically accelerating the hepatitis B response in Zambia. So the purpose of this program really is to raise awareness on hepatitis B amongst the general populace as well as our healthcare workers. But the overarching goal really is to build specialists, local hepatitis B specialists within Zambia. So we are targeted about 15, and then these are going to mentor other doctors across the country. So as has already been alluded to by Dr. Vinikoor, there are a lot of gaps in terms of the burden of hepatitis B in Zambia. So as part of our baseline study, we did a data collection just to understand where we are as a country in terms of testing, treatment, availability of reagents, and also to be able to do an evaluation at the end of our program. So we went to 4 different provinces in Zambia, including Luapula, Eastern, Western, and Lusaka, where we visited about 29 facilities. So the table down here shows the disaggregation in terms of age and sex on the status of the patients. So in total, for the disaggregated data, we had about 11,372 people or tests recorded across the 4 provinces. And then we had out of these, 621 were reactive, breakdown of this was that 50% were in the female population and 45% in the male. The median age was 32, as you are aware by now, I'm sure. It's Hep B is more active in the third decade of life. So this slide basically shows the breakdown of the tests recorded by province. In total, we had 40,773 testing non-reactive, and 2,423 testing positive. This translates to about 5% positivity rate. Okay. So our general observations as we did this surveillance were as follows. Okay. The hepatitis B surface antigen test was being performed exclusively in the labs using serum samples. We also learned that 14% of the sites, the hepatitis B surface antigen reagents were out of stock, and in fact, at some sites, the reagents had expired. I remember in Kaoma, there was an instance where the facility had about 900 test kits due to expire in a few months. Yet on a monthly basis, they couldn't even hit 10 or 20 tests being done. The challenge there was they couldn't share the test kits with the other facilities because the surrounding facilities did not have centrifuges for them to separate the blood. So beyond that, we also noticed a variability in terms of testing. The range, as you can see there, was from no tests at all being done in a month to 424 tests being done. So again here, several factors, maybe lack of test kits, and also could be that there was no demand, because when I visited the various ART clinics and MCH in particular, the clinicians there said they were not aware that they had to test the pregnant mothers. So maybe that explains the low level of testing. So as I said earlier, 6% of the tests were positive, and we also learned that there was universal availability of antiviral drugs for the co-infected, mono-infected, as well as the clients that are on PrEP. So in terms of treatment, the recording was rather poor. We learned that all clients, whether they're on HPV treatment, they're on ART or on PrEP, they're all being recorded in the dark. So it was a bit of a challenge to distinguish which client was receiving the drugs for which illness. So the next slide shows a distribution of test kits by ZAMSA. So after seeing the low number of kits or tests being done at the facility, we wanted to find out whether really was it that ZAMSA was not sending the test kits, or the facilities just were not doing the tests. So during this period, June 2020 to 2021, approximately 214,000 test kits were distributed by ZAMSA, and 33% or 70,000 thereabouts went to the various blood banks across the country. And then 10 and 9% went to district and general hospitals. The next slide shows the distribution of the kits by province. So Lusaka got a huge chunk of the test kits, that's 57%, on total 122,000 having gone to Lusaka. So We also observed some discrepancies in the numbers reported from ZAMSA and what was actually on the ground. In some instances, we found that the ZAMSA figures were lower than the actual tests being performed at the facilities. So this could have been due to the fact that the facilities are sharing test kits amongst themselves, or in some cases they have a budget line to purchase the test kits as and when they ran out, and also probably support from the supporting partners. Thank you. That's the end of my presentation.
Questions?
Thank you very much for that presentation. And I guess I was calling what happened in Laumia. Inspired, we shared with the other facilities. Because the reason why they do that was very bad. But I see that when you come to this thing for these are using plasma, it's ceramic. So if you are using ceramic, you don't need to separate it, but that's a little bit stand for some time. You can put it ceramic, so I don't really know why such the amount of kids were allowed to expire.
Yeah, I think to respond to that, I think it's the type of kits that they had. So the issue is, I'm not sure whether it's the buffer that they come with. So they would send you a pack of maybe 100 kits with only 5 buffers. So what do you do with the 95? That's where they were stuck, yeah. So as a result of that, they don't do much. Yeah, thank you.
Yeah, I mean, I think more than just Kaoma, we saw some kind of maybe mismatch where some facilities had reagents, but they weren't using them. Other facilities were doing a lot of testing and they would run out of reagents. So it seems like, again, awareness and training of health workers that can start to use the resources they're given to do testing. And then the other comment is, for the rapid hepatitis test, there are various types on the market, and there are three types which allow you to test on whole blood, like we do in HIV. So they determine, for example, we know determine, right, from HIV. And there's also BioLine, we know BioLine, right? And so those also make for hepatitis B. And so those are very good kits for us to have because our staff is very comfortable with them and they can be, the testing can occur outside of the laboratory. I think from my own experience, just like in HIV, if you have to collect blood with phlebotomy, bring to the lab, wait for the lab to do the test, and then bring back the results, you could lose clients that way. So if we can do it at the point of care within 15 minutes, it's much better. So this was actually just our baseline. It gives us a lot of information about what are some very low cost things we could do just by educating the facilities about who should be tested. We could start using the test more broadly. I think there was one facility where they were only using the test kits for certain patients and they were restricting them from others. Do you remember that?
Yeah, so just to add on to what Dr. Mike is saying, in certain facilities, testing was only being done on clinical suspicion. So unless the clinician orders a test, it will not be done. The kits will just be there. And yeah, in the end, they expire and whatnot.
Yeah, and I think Bob, when you debriefed us, you said that you ask them about their awareness of the guidelines, and they said, "Oh, we didn't even know there were guidelines on testing." So again, I think even though there will be resource challenges in this area, just by giving information, I think we can already start making improvements in our strategy. Okay, so now we're going to have another breakout session. So you're going to get back into your 3 groups, right, Mildred? Okay. Why don't you explain?
Okay, so we're going to.
Group 2, our question was HPV birth dose must be given within 24 hours of birth to be effective. However, in Zambia, some women deliver outside the facility. Please brainstorm, identify some ways to prevent this prevention gap. So what we
The point is. Yes, Aaron.
So what we came up with was, the first one was that we need to do routine testing of all pregnant women for HPV. So when the women come for antenatal, you have to make sure that all of them are tested for HPV in order that we don't miss anyone who might have the infection. Then other than that, we need to have a record of all HPV positive mothers, starting from antenatal. So we make sure that all the women are recorded in a register. We need to come up with a register where all the women are recorded. And then they'll obviously go home. So we have to make sure that we engage the community-based volunteers or the SMAGs in tracking the positive women. Then community sensitization through health education on HPV birth dose vaccine. We have to make sure that all the women are aware of that, especially the positive ones. They need to be aware that they need to get this, the baby needs to get the dose after delivery. So they have to be sensitized. Then we encourage the mothers to wait at the mother's shelters to await delivery at the facility. At least by the 8th month, they need to come and wait so that when they deliver the facility, they'll be given the dose. Then we also have to make sure that the logistics for HPV should be available at the facility. So the doses, the vaccine should be there, the cold chain should be available, and to top it all, the staff should also be knowledgeable. I think we had in the morning where one of the clients was actually made to wait for a long time for the baby to get the vaccine. So we have to make sure that the staff also know what they're supposed to do in order that the dose is given within 24 hours. I think that is where we ended.
Very much. Are there any questions or comments? So this is a big concern of people in the hepatitis B field that in Africa, there are still a lot of non-facility births. So how can we get timely birth dose, especially in rural areas? So there are some intense area of discussion how we can do this. There's even some really interesting innovations I should tell you about where there are vaccines without needles. They can be given almost like putting a plaster on and taking it off. So there's some pilot work being done to see if moms or traditional birth attendants could be trained to put the plaster on a baby and take it off, to give it like a jab without a needle. Obviously, if something like that is allowed to happen for other vaccines as well. One question I have for you is, are facilities able to know which moms will deliver in the facility or not? Are moms likely to say that they won't deliver in the facility before it actually happens?
So generally during antenatal care, the women are educated, they're given the dates that they're expecting to deliver. So it's expected that every woman is supposed to know. And they should prepare also the person who's coming to them for delivery, so the support person. So generally they know when they're supposed to do.
There's a contribution program.
For our country, I think it's difficult to know who will come to the facility because we think if they are going to their mother's hometown to deliver, so you really want to come to give us a facility. Yeah, I think that's a challenge because of this migration between the different.
Okay, thank you. Let's have the next group round of applause. Chat, who's up next?
So we have 2, 3, 4 currently. So any of the ones that haven't yet. 3? Okay. Just a second. There's a pointer there. Just a second. Just a second. So you'll be pressing the arrow. Just like pressing this arrow. Just like.
Okay.
Yeah. What are you doing?
Hi everyone, I'm Veronica Lesa from Luangwa, presenting for Group 3. Our question, rather scenario, was on scaling up hepatitis B elimination activities. So on the implementation scenarios, I'll just read through the question and the fact of the question, then we can go on to what we discussed as a group. So scenario 1 was on prevention of mother-to-child transmission of hepatitis B. So the fact of the scenario is that hepatitis B virus birth dose vaccine is an effective way to interrupt mother-to-child transmission and is considered by global experts to be the most cost-effective intervention to lower the transmission from mother to child. Hepatitis B birth dose should be given to the baby within 24 hours of birth. After 24 hours, its prevention benefits reduce. So our discussion was on part 1 of the assignment, which is debate the 2 major strategies to help, debate the 2 major strategies to deliver hepatitis B virus birth dose as proposed by World Health Organization. So approach 1 was the targeted approach, and 2 was the universal approach. So in our question and our group, we decided that the universal approach would work better in our setting because we looked at the number of limited test kits the problem of limitation to number of test kits that we tend to experience in our facilities. So in such cases, we tend to miss out on testing a lot of mothers, especially during their routine test and bookings. The other reason why we went with the universal approach is that missed antenatal mothers, there are several mothers that tend to miss their antenatal bookings and just show up during delivery. This has been noticed especially in our rural settings. Mothers tend to shun away from accessing antenatal services and rather just show up on the actual day. So in such a scenario, we would find ourselves not having the means to test the mother before the delivery happens. because they show up to facilities when they're already in active labor. And then the other reason we thought of using the universal approach is that implementation of policies in facilities is very poor. It is, most of the healthcare workers are aware that we are supposed to test mothers for hepatitis B during the first ANC booking, but it is not something that is routinely done. We tend to just focus on doing the full blood count to check for their HB levels and also the syphilis and other tests, but hepatitis B is not something that is routinely considered by most of us healthcare workers. And then the other reason we thought of going with the universal approach is because that it will lower the chances of transmitting the HPV to the babies compared to the targeted approach, because all the babies in this instance, even if the mother was not tested during ANC, will access the benefit of not getting the disease because they will all acquire the immunity they need to not get the virus. So I think that's why we ended. We had started tackling the other question, but this is where our approach was ending. Thank you.
So just to follow up, the targeted approach where you screen the moms, looks like you identified that the limitations of that are if testing kits run out, it falls apart. If moms travel, it falls apart. Are there any other limitations you saw to the targeted approach?
Besides the issue of testing kits running out, I think the major challenge with the targeted approach is that the implementation of policies with the healthcare workers. I think that's why it's not really the best one in our case. I don't know if the team has anything else to contribute on that one.
Sure. Just as an addition, currently it's policy that all antenatal mothers are supposed to have an hepatitis B surface antigen test. I don't know the statistics, but still the testing from the experience point of view, we have lots of mothers who have attended antenatal visits, but they have not had their hepatitis B surface antigen test.
Are babies at your facility being given any other injections right there at birth, or these could be easily taken up by the nurses? I mean, is that, I don't know if they're receiving any other injections that you are babies.
Can you just repeat the question, sorry?
Yeah, are the babies already receiving any injection of any kind at birth?
At the facility that I was at, not that I know of. I don't know about experiences with the other facilities.
They receive BCG.
At birth. It's even at day 6. First visit.
So there is a vaccine, BCG, which is given at birth. It's only in certain circumstances when they fail to give at birth that they are encouraged to give at but there is a vaccine which is even in the immunization program. It's there and means to be given at birth. And what we will do is that one will be all one.
Does anyone else want to comment on how, because it sounds like the BCG at birth or maybe at birth is not always at birth.
Yes.
Sometimes at 65 days of life. Does anyone else's facility that actually gives it right at birth?
So, ideally, BCG is supposed to be given at birth, but they're not being given right there. Usually, when they follow the to avoid the risk of vaccines. That's one thing I have noticed. Yeah. So ideally it's supposed to be done like that, but it's already stated that policies are there, but it's taken vaccines are not prepared for. Maybe the vaccines might not have the vaccines at the time the children are born. So there are those weaknesses in the system, but ideally this is supposed to be even be done in care, but it's not something that is emphasized. So it's very good. So policies are there, but implementation has to be good. Ensuring that everything is implementation.
Any other contributions? Okay, I think with one more group, please come up.
Ready.
Good afternoon. Good afternoon. Number next measure for Senanga District, Western Province. Okay. So we are in group 4, and our question was on the indicators pertaining elimination of hepatitis B in PMT-16. So the fact, by 2020, we hope to reduce hepatitis B virus mother to child transmission to 0.1% of under 5 or to less than 2% of children born to hepatitis B positive mothers. Assignment, brainstorm how you could track these indicators at your facility. So as a group, we thought of coming up with this. The first thing is to incorporate hepatitis B in the already existing data capturing tool. We realize that most of the data capturing tool that we have in ANC we have a lot of registers, but none of them has a component of hepatitis B to allow us capture the data. So instead of us producing new registers, we thought if it can be incorporated in the already existing register, it would be very easy for us to use. So these registers that you need incorporation of hepatitis B data are the ANC register, the antenatal card, so that the mother's hepatitis B status can be ascertained just at a glance. Then the delivery register, the mother pair register, the baby mother pair register, and the under 5 card. So incorporation can be a first step towards indicator tracking. Then the second one is the hepatitis B start. We named it as such, so as to make it mandatory so that every woman who comes for first ANC booking can be tested for hepatitis B and the status be documented in the ANC register. Then those that test positive, they should be identified. That is the hepatitis B positive mothers in ANC, they should be identified. Then the third one, hepatitis B positive mothers to be enrolled into care. So on the care, those that need the treatment in terms of the pharmacology treatment, they can be given. Then hepatitis B vaccinated mother, we should also ascertain the number of women who come for ANC booking with the vaccinated status of hepatitis B. Also incorporating hepatitis B data in the already existing monthly reports would help us track the indicator. It's like we have a weakness in this. This is the end of the presentation as for group 4. Thank you.
just add on that if you want to check a baby's hepatitis B status, maybe for baby born 1 of these months, you have to do it at 6 months or beyond. So you, like the way we do for HIV, we used to do it 6 weeks and 6 months. It's 6 months.
Okay.
The other question I want to ask you is, how feasible is it to add items to the registers? I mean, I've seen that they're so packed with information that every single column is used up. So is it realistic that you would come in and be given 2 or 3 more columns of information?
The register are packed, but we felt incorporating can be easier than producing a new register, since the MCH department is already packed with a lot of registers. So for it, like for the ANT, if it is incorporated, one can ascertain the hepatitis B status at a glance. Just opening the register, you're able to isolate those are the tested one, the positive, and the intervention done.
Comments, other contributions?
We have a question. The recommended frequencies of tests before we roll it out to the MCH, how often would these then have to be tested?
Yeah, that's a very, very good question. Right? So if we had a way of knowing mom's status of the whole test, then these would need to be retested each pregnancy. Because the rate of new cases among adults is very low. Most of our new cases are babies. So that would be theoretically possible, but I just don't know how easy it is for someone to show their status from 1 year to the next and they get pregnant again. So it might be more operationally feasible just to test every pregnancy. I don't know. Certainly, internationally, everyone just recommends testing at every pregnancy because the testing kits are cheap. But for us, when we have shortages, maybe we should take another approach. That answers your question. All right, thank you very much. I think those are all the groups. So just 1 minute or 15 minutes. We should be wrapping up.
Thank you.
It would also help us to know which of the sessions you feel are high impact that we should repeat multiple times, whereas other sessions maybe could just be given once. Yeah, so really, Zambia has hepatitis guidelines since 2019, and so really we're promoting the implementation of those guidelines, what we do through Project ECHO. And as Bob mentioned, we have a small grant to help us with our education coming from the Hepatitis Fund in Switzerland. And so our program is called Accelerate. It's funded by NHEP 2030 or the Hepatitis Fund. Dr. Kankaso from UTH Health is the PI, Dr. Sakal and I are co-directing it. And really this is an educational program trying to build awareness and clinical competency. So when we developed the proposal for these funds, we identified these barriers on the right as they're like fundamental things that are holding us back in hepatitis. There are many things, like obviously money is one thing which holds us back, resources. But we found these were like really fundamental, these 3 things. So fundamentally, as many of you have already picked up on the fact that there's low awareness in the general population. That's like a fundamental thing that's holding hepatitis back. And then another thing we recognize is there just aren't enough local experts. I mean, you see Dr. Sinkala and I are both here. but throughout the week, how many HIV experts came to talk to you from CDC, from HAP, from other organizations? I'm sure you had more than 20 experts visit you to give talks. It just shows that HIV experts are common now. There's so many of them. They're even super expert. Like there'd probably be an expert of PrEP, an expert of tenofovir, an expert of DTG, an expert of TB, you know. So at this point, we don't have such experts. We want to have an expert on birth dose. We want to have an expert on Hep B, PMTCT. We want to have an expert on different things within hepatitis. So basically, getting more local experts is one of our priorities. And then finally, we want to raise up the level of competency of the average clinicians who are out there taking care of most of the patients in the country. So we've already started working on a local experts angle. So we actually have, maybe some of you are involved in this. I know several people from LPHO have joined recently. But we've been, we basically recruited or accepted about 40 doctors into this program. And we originally focused on people who are doing MMeds, because we wanted someone who's very clinically focused. And we picked from different departments, such as infectious disease, OB-GYN, PEDS, GI, internal medicine, and CDH. And then we were also involving 12 medical officers from LPHO, one from CITES, one from ZED and PHI. So starting in September, we put them through about 11 different lectures. They went over some sample cases. And then we launched the hepatitis clinic at ETH AIDC. So if you're in Lusaka and you have a Friday morning available, and you want to pass through and see some cases like the ones we saw, but even more, we have a clinic on Friday mornings. So in just a few months, we've managed to recruit more than about 84 new patients, and we had 18 follow-ups.
So maybe you can switch off from
Okay, no problem. Even though I was being heard upstairs.
Yeah, we just connected you to upstairs.
Okay, no problem. Should I start over?
No, it's fine. Just proceed.
Okay, great. So yeah, so just from September to November, we've enrolled about 84 new patients with hepatitis B into the clinic. So that's about 10 a week. And then we also had some follow-up visits. And our mentees, these junior developing doctors and some from LPHO, are there seeing the cases with at least one expert from among the few that we do have. And then in addition, there's also a special Project ECHO, which is hosted in Cape Town, South Africa, for hepatitis experts. So it's not like the one we have in Zambia, which is reaching all around the country. This one is just for GI, ID, and hepatitis, hepatitis-loving doctors from around the continent of Africa. And so that happens every 1 to 2 months. And our students participate. So I want to talk about ECHO. So, ECHO is an amazing tool. It's really taken off impressively. When we wrote our proposal for funding, there were only, I think, 60 spokes in Zambia. And now we might be reaching 160 or 200. It's massive. And so we have come up with a curriculum that we wanted to discuss with you all. And so we identified these 9 session topics that we think would be important. And so I'll just read them out. So the top row are really our high priority 3. So HBV mono infection, antiviral therapy criteria. This is the one we gave on Monday. B, the second one there is hepatitis B testing priorities and results interpretation, and then integration of Hep B into ART clinics. In the second row, we have hepatitis B treatment monitoring and when to stop. Then there's co-infection management, PMTCT. And then in the third row, we have HIV, HBV integration, kind of like the session I gave you earlier today, looking at PEP and PrEP, stigma, and other areas where there's integration and intersection. And then we have a session about the other types of viral hepatitis, because although we focus on B, we can't ignore the fact that you might encounter a case of A, E, or C in your practice as well. And then finally, a session on hepatitis B in children. And so these are the 9 that we have come up with. And so I was just wondering if anyone can give us feedback if there's something missing, more importantly, or is there anything from row 2 or 3 that they think should be pushed up to the higher priorities? Because we thought that probably the high priority topics we could even repeat during the year. Whereas the other ones, if we don't have time, we just hit them on one occasion, one echo session. And so the idea would be to build each of these into an echo session that could be delivered in the country. So let me just stop there and see if there are anyone wants to give any feedback. Yes, doctor, please.
You have to come in because others have joined upstairs.
Okay, someone's coming up to give me some feedback.
Good afternoon. This is Chifasha. I would like to propose more than one echo session regarding the monitoring and treatment and when to stop the therapy, because this is a question that we keep asking quite a lot. Thank you.
Okay, thank you. Anything else? Yes, why don't you say and I'll repeat.
I would suggest that the session on hepatitis
Okay.
Considering the fact that most new infections will be children and the prevention also focused on preventing it in children.
What's your name?
Charles.
Okay, Dr. Charles has said that he would recommend making hepatitis B in children a higher priority, especially looking at those indicators that we're going to be chasing after, reducing on new cases in young children. I think that's a great point, because that could also bring in the angle of PMTCT, which could then be emphasized in 2 sessions. And then there was a hand over here, yes?
Then I would suggest prevention of HPV transmission.
Okay, Dr. Alex also wants to emphasize more on PMTCT. Thank you. Anything else? Okay, that's great. It's very helpful. And so how are we going to actually do this? So I do want to say that, the ECHO program has really taken off, but I'm hearing from the experts who implemented week by week, Dr. Foloshi and Ziambo, that there is a degree of burnout. There's so much content, there's so many sessions, and so there's a question of how are people really, is the information really sticking on the other end? And at the same time, there's a lot of topics to be delivered through ECHO, because now that we've seen here in Lusaka that we can give information so quickly to all of the provinces, it's like there's so much information we want to give you. And so as we've been working with the HIV-TB program, it seems like the curriculum is already very expansive. So it's unlikely that we'll be able to give all of these sessions on the Monday time slots. So we're planning to think about some different approaches on how to give these sessions. So for example, there's what we're calling ad hoc. So we will prepare the session, the speakers, the cases, but then we'll keep it in the bank. And when the ECHO, TB, or HIV, if they have a cancellation for some reason, we can come in at the last minute and take the Monday slot. So that's what we did this Monday, actually. We were only contacted on Thursday or Friday, to say, can you jump in and take this Monday slot, because we were thinking of canceling. So that's one approach. Another is to give our echo on Thursday. So you might be, I don't know if you all participate in those Thursday echoes, but there are Thursday echoes focused on advanced HIV and COVID-19. but I've been made aware that some of the Thursdays are not taken up already. So we could add hepatitis like once a month on a Thursday session. That would be another option, although the downside of this is that I've been told that fewer people join on those than at the National Monday one. And then finally, we're looking at kind of taking advantage of holidays. And so after I show you the last slide, and I'll ask your feedback also about this, and then we'll be done. So I'm trying to come up with a clever way of framing this. We're calling it Happy Holidays. Okay, no one laughed. But basically, as you may know, the ECHO program is going to go on holiday break in the next few weeks. And so there are these 3 time slots which are available, and many people will still be in the facility then, you know, they won't be breaking for holidays. So we were thinking of giving some of our high impact talks on those Monday sessions. And then, you know, those who are very interested can tune in and we'll be there to provide them that information. So we're thinking tentatively to give our hepatitis testing talk on the 6th, to give something about integration into ART programs on the 20th, and then after the new year on the 10th, PMTCT. So are there any comments or contributions about these strategies to try to start integrating ourselves into the hepatitis or into the ECHO program that you're already receiving? Any feedback from anyone, whether you think this can work, whether you can see other ways for us to give out this information about hepatitis? Thank you. So let me get a show of hands. Okay, let me get a show of hands. Who tunes into Thursday Echoes right now? Is that something you're required to do? I'm only seeing 1 hand. 2. So there was an advanced HIV the other Thursday, right? How many tuned into that one? Dr. Seville, no, it was Dr. Capata, I think, TB. Very few, okay. So very few tune out on Thursdays. All right, let's go to you, please.
My comment is on the happy holidays. Well, as it is now, there's even some talks on Zoom burnouts. And I can say usually at facility level, sometimes we do look forward to these echo breaks. So that when you get back a little more rejuvenated. And I don't know how it's going to work out, having to put in some other sessions on the aspect of attendance. Yeah, I just feel that they could be slotted quite all right, but I foresee a situation where the attendance might not be as good as hoped for, might not give the intended effect. Thanks.
Thank you. Yeah, comment well taken. Any other comments or feedback? Okay, so the Thursday session, the challenge will be that most of you won't be there. And Mondays over the holidays, again, you might be there, might not, but many people will be thinking of having a break. Okay, so let me just see if there are any other thoughts or contributions before we wrap up. So we are being given some Monday slots for hepatitis. It's just that to accommodate all of these lectures may be too difficult. Yes? The comment was whether we'll need the cases from the facilities or whether we'll bring our own cases for the holiday sessions. Yeah, I think in that case, we'll be able to provide our own cases. But yeah, no, in general, we do want to start engaging. Now that you've become more enlightened, illuminated about hepatitis, I'm sure in your natural day-to-day work, you'll see cases. And so when we reach out to you asking for a case in the next 3 to 6 months, some of you will be right there saying, I had this, I had that, I've seen this, because there are a lot of patients out there, and so you will see them. But no, if we have to, we have cases. Thank you. All right, I think we can wrap up this session, and then I'll hand it over to Mildred just for any announcements for tomorrow. But I just want to say on behalf of our program, we're very grateful for you to stick around with us up till today, and your participation on the session, the breakout groups was great. Those information and brainstorm sessions, we're actually going to, use that for our report. We'll should probably be sharing with Ministry of Health. And so it's just been great interacting with all of you. And I hope to see you more tomorrow. Thank you.
Good afternoon, everyone. Good afternoon, Team Mulungushi, the team that's above. So